Welcome to Lecture Boss. My name is Dr. David Averbach, and today we will discuss the best treatment options for the most common cardiovascular conditions that appear on steps 1, 2, and 3, and the shelf exams. This is the second of two lectures on this topic. We have a student in the hot seat today who will answer my questions. Let's discuss the management of arrhythmias. We will start with tachycardias. We will divide these into ventricular tachycardia and supraventricular tachycardia, or SVT. Let's start with the SVTs. We will further group those into paroxysmal SVTs, those that start and end abruptly, such as AVNRT or AVRT, and non-paroxysmal SVTs, such as atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. These two groups of SVTs are managed differently. How do you manage a patient with a paroxysmal SVT, such as AVNRT or AVRT, that involve reentrant pathways?
If the patient is hemodynamically stable, you start with vagal maneuvers to slow conduction through the AV node, such as carotid sinus massage, Valsalva maneuvers, or an ice pack on the face.
Correct. What if these measures don't convert to sinus rhythm?
You could administer adenosine to slow conduction through the AV node.
What if adenosine is ineffective?
You could give a beta blocker or non-dihydropyridine, calcium channel blocker such as verapamil or diltiazem, or perform synchronized cardioversion.
Good. What if the patient is hemodynamically unstable with AVNRT or AVRT?
You perform synchronized cardioversion.
What is the definitive treatment for AVRT or AVNRT?
You perform catheter ablation of the reentrant pathways.
That's right. Second-line therapy is maintaining the patient on beta blockers or non-DHP calcium channel blockers. Wolff-Parkinson-White syndrome involves an accessory pathway from the atria to the ventricle and is associated with AVRT and sometimes atrial fibrillation. It usually presents after 10 years of age. How do you treat WPW?
For acute episodes in hemodynamically stable patients, you perform rhythm control with procainamide or do synchronized cardioversion.
Good. It is important to avoid AV nodal blocking agents in Wolff-Parkinson-White because these can increase conduction down the accessory pathway. What if the patient with WPW is hemodynamically unstable?
You perform synchronized cardioversion. Definitive treatment would be catheter ablation of the accessory pathway.
Correct. How do you manage a patient with atrial fibrillation, atrial flutter, or multifocal atrial tachycardia?
If the patient is hemodynamically stable, you perform rate control with beta blockers and non-DHP calcium channel blockers to slow conduction through the AV node.
That's correct. If the patient's multifocal atrial tachycardia is caused by COPD, use beta blockers with caution. What if rate control is unsuccessful for AFib?
You perform rhythm control with either class 1C antiarrhythmics such as flecainide or propafenone, class 1A antiarrhythmics such as procainamide, or class 3 antiarrhythmics such as amiodarone or sotalol.
Very good. If the patient is hemodynamically unstable, you perform synchronized cardioversion. How do you assess a patient's risk for a mural wall thrombus with atrial fibrillation? And how do you prevent these clots?
After treating the patient's arrhythmia, calculate their stroke risk using the CHADS VASC score. If their score is 0, no treatment is necessary. If their score is 1 point, the patient should take aspirin. If their score is 2 points or more, the patient should take anticoagulants.
Correct. Which medications are preferred for long-term anticoagulation?
Direct oral anticoagulants such as apixaban, a factor X inhibitor, or dabigatran, a thrombin inhibitor, are preferred because they have less adverse effects and you don't have to monitor the INR.
Very good. Apixaban is sometimes preferred because it has a lower bleeding risk and is safer in patients with renal dysfunction. What if the patient's atrial fibrillation is caused by a valvular etiology, such as mitral stenosis or an artificial valve?
Then warfarin is the preferred drug.
Yes. Which medication would you use if the pregnant woman had atrial fibrillation?
Heparin would be the drug of choice because warfarin and direct oral anticoagulants are contraindicated in pregnancy.
That's correct. What is the initial management for a patient with sustained ventricular tachycardia?
If the patient is hemodynamically stable, you would use amiodarone, sotalol, or procainamide.
Good. Your drug choice may be guided by the side effects or if the patient has an implantable defibrillator. What if the patient with VTAC was hemodynamically unstable but had a pulse?
You would perform synchronized cardioversion. Amiodarone could be given if this is unsuccessful.
Correct. What if the patient has pulseless ventricular tachycardia?
Perform defibrillation and CPR.
Yes. What is the long-term management for ventricular tachycardia?
Give the patients beta blockers, or if the VTAC is refractory, they can receive an implantable defibrillator or have catheter ablation to remove an ectopic focus or reentry circuit.
Good. What if a patient with a long QT interval develops torsade de pointe, a polymorphic ventricular tachycardia?
Treat the patient with magnesium. Also identify the underlying cause, which is most commonly a medication.
Correct. The medications most commonly prolonging the QT interval are class 1A or class 3 antiarrhythmics. There are 4 cardiac arrest rhythms you should recognize. For 2 of these, you perform defibrillation. In addition to pulseless VTAC, for which other cardiac arrest rhythm do you defibrillate?
Ventricular fibrillation, most commonly arising from coronary artery disease.
Correct. What other resuscitation measures are part of the ACLS algorithm for these 2 cardiac arrest rhythms?
You will first perform defibrillation and CPR. If these measures don't convert to sinus rhythm, administer epinephrine. As a last resort, you can administer amiodarone.
Very good. Which two cardiac arrest rhythms are non-shockable?
Pulseless electrical activity and asystole.
Yes. How do you treat these two arrest rhythms?
With CPR and epinephrine.
That's correct. Let's talk about bradycardias, focusing on AV blocks. How do you treat a second-degree heart block, Mobitz type 1, if the patient has unstable bradycardia, with symptoms including syncope, altered mental status, shortness of breath, chest pain, or hypotension?
You administer IV atropine, an antimuscarinic to reduce vagal tone on the heart.
Good. What if IV atropine doesn't sufficiently treat the bradycardia?
Perform transcutaneous pacing. You could also add epinephrine or dopamine to the pacing, or use epinephrine or dopamine instead of transcutaneous pacing.
That's correct. If this doesn't treat the bradycardia, you could try transvenous pacing. How do you treat second-degree heart block, Mobitz type 2, or third-degree heart block?
If the patient has unstable bradycardia, manage him the way we discussed for Mobitz type 1. Afterwards, the patient with Mobitz type 2 or third-degree heart block will need a permanent pacemaker.
Very good. How do you manage a thoracic aortic aneurysm?
You perform surgery if the patient is symptomatic, or if the patient is asymptomatic, but the aneurysm is greater than 5.5 centimeters or growing more than 0.5 centimeters per year.
That's correct. You will do emergent surgery if the patient is hemodynamically unstable because the aneurysm is ruptured. What are the surgical options?
For an aneurysm of the ascending aorta, the most common type, perform open surgery. For an aneurysm of the descending aorta, perform endovascular repair.
Good. How would you conservatively manage a thoracic aortic aneurysm?
You want to lower the patient's major risk factors for aneurysm enlargement by decreasing their blood pressure and smoking cessation. Optimizing their lipids is also important.
Correct. How do you manage an abdominal aortic aneurysm?
You do urgent surgery if the patient has signs and symptoms of impending rupture, or if the patient is asymptomatic but the aneurysm is greater than 5.5 centimeters or growing more than 1 centimeter a year in men. You do emergent surgery if the aneurysm has ruptured and the patient is hemodynamically unstable.
Very good. What are the surgical options for abdominal aortic aneurysms?
Endovascular repair is indicated for most AAAs.
That's correct. How would you conservatively manage an abdominal aortic aneurysm?
You advise smoking cessation, the major risk factor for aneurysm enlargement. You also reduce other atherosclerotic risk factors by optimizing their lipids, lowering their blood pressure, and glucose control if they're diabetic.
Good. Let's discuss aortic dissection. How do you treat an aortic dissection once you've confirmed it by imaging?
If it's a dissection of the ascending aorta, type A, you must do emergent open surgery and repair the dissection with a synthetic graft. If it's a dissection of the descending aorta, type B, you can medically manage it with blood pressure control.
Correct. What medications do you use to control the blood pressure?
First, give the patient a beta blocker such as labetalol or esmolol to slow the heart rate and reduce further damage to the aorta. Follow this with a vasodilator such as clevedipine or nitroprusside.
Very good. It's important to give the beta blocker first to prevent reflex tachycardia. If complications develop from a type B dissection, such as ischemia to distal organs, you must perform surgery. Let's discuss the treatment for carotid artery stenosis. What is the medical management?
Patients with carotid stenosis will be given medications that reduce the risk of atherosclerosis, such as antiplatelet agents, statins, and antihypertensives, such as beta blockers or ACE inhibitors.
Correct. What are the indications for surgery in carotid artery stenosis?
If the patient is symptomatic and has stenosis between 70 and 99%, you perform revascularization. Revascularization may also be considered for symptomatic patients with stenosis greater than 50%.
Good. What surgical procedure do you perform?
Carotid endarterectomy is preferred because it has a lower periprocedural stroke risk.
Are there alternatives to endarterectomy?
Carotid artery stenting is another option. It has a lower periprocedural MI risk and may be better for patients at high risk of complications from endarterectomy.
That's correct. Do you perform surgery if a patient has asymptomatic carotid artery stenosis?
If a patient is asymptomatic and has stenosis between 70 and 99%, revascularization can be considered. If a patient is asymptomatic with stenosis between 50 and 69%, revascularization is not usually recommended. The patient can be medically managed as discussed earlier.
Very good. Let's discuss the treatment for intestinal ischemia. What is the initial management for acute mesenteric ischemia?
You will administer oxygen, IV fluids, antibiotics, and perform nasogastric decompression. You will also give unfractionated heparin.
Correct. The cause of the ischemia is usually an embolus in the superior mesenteric artery, often from AFib, and you must perform revascularization. What are some procedures that you can do?
You can perform endovascular techniques, including mechanical removal of the embolus with a catheter. You can also locally inject thrombolytics or vasodilators, or you can place a stent.
Yes. What if the patient with acute mesenteric ischemia is hemodynamically unstable or shows evidence of intestinal ischemia or peritoneal signs?
You must perform emergent laparotomy and possible bowel resection.
That's correct. How do you treat chronic mesenteric ischemia?
Chronic mesenteric ischemia is most often due to an atherosclerotic plaque in the mesenteric arteries. These patients should undergo an endovascular procedure such as angioplasty and stenting.
Very good. If this procedure doesn't work, You could attempt open surgery with bypass or endarterectomy. How do you treat colonic ischemia?
Colonic ischemia is most often non-occlusive and is due to hypotension or shock. Treatment involves supportive measures such as fluids to increase blood pressure. Most cases resolve spontaneously.
That's right. What if the patient is hemodynamically unstable, has peritoneal signs, or heavy bleeding?
You must do emergent laparotomy and possibly bowel resection.
Correct. Let's discuss the management of renal artery stenosis. How do you treat this medically?
Most cases of renal artery stenosis are due to atherosclerosis. So you control the risk factors for atherosclerosis using statins, antiplatelet therapy, and ACE inhibitors.
Good. In addition to ACE inhibitors, the patient may have to take multiple drugs to lower their refractory hypertension. The other major etiology of renal artery stenosis, fibromuscular dysplasia, may also require multiple antihypertensives. An important point is that you must be cautious using ACE inhibitors in patients with bilateral renal artery stenosis. The drug could lead to a significantly reduced GFR, and this may be evident if the patient's BUN and creatinine rise after administration. What is the surgical treatment for renal artery stenosis?
Surgical indications for renal artery stenosis include hypertension refractory to medications, greater than 70% stenosis, or bilateral renal artery stenosis. You perform endovascular repair with angioplasty and stenting. You could also do surgical repair with aortorenal bypass surgery if stenting is not successful or there are contraindications.
That's correct. How do you manage peripheral artery disease?
If the patient has symptoms such as intermittent claudication, start with a structured exercise program. In addition, give the patient medications to lower the ASCVD risks, such as antiplatelet agents, statins, antihypertensives, and glycemic control.
That's right. What if the exercise program doesn't improve symptoms?
You can add cilostazol, which is an antiplatelet and vasodilator.
What if symptoms don't improve with cilostazol? Or the patient has chronic, limb-threatening ischemia with ulcers and gangrene?
You perform revascularization using either endovascular or surgical procedures, depending on factors such as the location and size of the occlusion.
Correct. What if the patient develops acute limb ischemia, for example, from an embolus due to AFib or from a cholesterol embolus?
You begin systemic anticoagulation with heparin and then perform revascularization. This can be done with endovascular procedures such as catheter-directed thrombolysis or aspiration removal of the embolus. Surgical vascularization with bypass can also be performed.
Very good. Let's discuss the treatment for a deep vein thrombosis. What are the medical options?
Patients with acute DVT are given low molecular weight heparin, or alternatively, unfractionated heparin if they have renal disease. You will follow this with long-term anticoagulation using the direct oral anticoagulants. If the patient is pregnant, use low molecular weight heparin instead.
Very good. What if these medical therapies fail to resolve the DVT, or if the patient has contraindications to anticoagulation?
You can perform catheter-directed thrombolysis with TPA. You can also do thrombectomy, and this would be preferred if patients have a contraindication to TPA.
Correct. If patients have a contraindication to either TPA or thrombectomy, or have a high risk of pulmonary embolism, you could place an IVC filter. Let's discuss the treatment of chronic venous disease, which includes varicose veins and chronic venous insufficiency. In addition to lifestyle changes, such as exercise, elevating the legs, and avoiding prolonged sitting, what other modalities are used?
For mild disease, you can use different grades of compression stockings. Make sure that the patient doesn't also have peripheral artery disease.
That's right. What if conservative management is inadequate, or the patient has symptomatic varicose veins or chronic venous insufficiency with edema, skin changes, or ulceration?
You use minimally invasive treatments, including thermal ablation of veins to seal them off. Surgical options include repairing the valves of veins or removing the veins completely.
That's correct. Let's discuss the treatment of vasculitis. Let's start with the large vessel vasculitides, giant cell arteritis, and Takayasu arteritis. How do you treat giant cell arteritis?
If the patient doesn't have cranial symptoms, such as a vision loss, TIA, or stroke, you give high-dose prednisone. If the patient does have cranial symptoms, give high-dose IV methylprednisolone.
Very good. Patients can then be maintained on oral glucocorticoids or steroid-sparing agents like the IL-6 receptor blocker tocilizumab or methotrexate. How do you treat Takayasu arteritis?
The initial treatment involves high-dose steroids, and then the patient is maintained on steroid-sparing agents such as methotrexate.
Correct. What if the patient with Takayasu is still symptomatic despite medical treatment?
If the patient is experiencing symptoms from occlusion of the aortic arch and its branches, such as limb ischemia, you perform angioplasty with stenting or bypass surgery.
Good. Let's discuss treatment for the medium vessel vasculitides, polyarteritis nodosa, and Kawasaki disease. How do you treat polyarteritis nodosa?
You give steroids and cyclophosphamide. The hypertension from renal artery occlusion can be treated with ACE inhibitors.
That's correct. If the polyarteritis nodosa is associated with hepatitis B, give Hep B antivirals such as the NRTIs tenofovir or entecavir. How do you treat Kawasaki disease?
You administer high-dose IVIG and aspirin to prevent coronary artery aneurysms.
Good. Let's talk about treatment for small vessel vasculitis, IgA vasculitis, and the ANCA-positive vasculitides, GPA, EPA, and microscopic polyangiitis. How do you treat IgA vasculitis?
Most cases of IgA vasculitis only require supportive care. But if there are severe symptoms, such as nephritic syndrome or GI bleeding, you give systemic steroids.
Correct. How do you treat the ANCA-positive vasculitides, GPA, EPA, and microscopic polyangiitis?
You give steroids and cyclophosphamide to induce remission.
Good. Cryoglobulonemic vasculitis is another small vessel vasculitis with precipitation of antibodies or immune complexes at temperatures below 37 degrees. How do you treat this condition?
Most cases are a mixed cryoglobulinemia, and you treat the underlying cause, which is commonly due to hepatitis C. If the vasculitis is severe, you use steroids or rituximab.
That's correct. Let's discuss the treatment of shock. What is the treatment for hypovolemic shock?
Fluid resuscitation with crystalline solutions such as normal saline or lactated ringers, or colloid solutions containing albumin. If there is significant blood loss, give blood transfusions. You can use vasopressors such as norepinephrine if the blood pressure remains low despite fluid resuscitation.
Very good. What is the treatment for cardiogenic shock?
You first administer an inotropic agent such as dobutamine to improve contractility. You may also co-administer a vasopressor such as norepinephrine.
That's correct. Norepinephrine is preferred because it will vasoconstrict without significantly increasing heart rate and myocardial oxygen demand, or potentially worsening an arrhythmia. If the cardiogenic shock is due to an MI, valve dysfunction, or an arrhythmia, you also want to treat these underlying etiologies. What is the treatment for obstructive shock? Often due to a massive pulmonary embolism, tension pneumothorax, or cardiac tamponade.
If obstructive shock is due to massive PE, you administer TPA or do thrombectomy. If it's caused by a tension pneumothorax, perform immediate chest decompression with needle thoracostomy. If it's due to cardiac tamponade, perform pericardiocentesis.
Very good. Let's discuss distributive shock, septic shock, anaphylactic shock, and neurogenic shock. How do you treat septic shock?
First, start with IV fluids and antibiotics. If the blood pressure remains low despite IV fluids, administer norepinephrine. In cases of profound shock, norepinephrine may be initially given with the IV fluids.
That's correct. If the blood pressure still remains low after administering norepinephrine, you could add vasopressin, which not only vasoconstricts, but also increases fluid reabsorption. How do you treat anaphylactic shock?
You administer intramuscular epinephrine and IV fluids.
Correct. Epinephrine is preferred because it can also cause bronchodilation by activating beta 2 receptors. What if the anaphylactic shock is refractory to these measures?
Use IV epinephrine and also consider using steroids or antihistamines.
Very good. An important point is that if the patient is refractory to epinephrine because he is on a beta blocker, consider using glucagon. What is the treatment for neurogenic shock, often due to a spinal cord injury?
Begin with fluid resuscitation as well as norepinephrine, which not only increases systemic vascular resistance, but also improves the bradycardia that's characteristic of neurogenic shock.
That's correct. If the patient continues to have bradycardia, atropine can be given. Thank you for joining us for the second of our 2 lectures on cardiovascular treatments. We hope you learned a lot. Additional notes on this topic will be available at lectureboss.com or by following the link in the video. Take care.